Hello, everybody. So over the past few days that we have been running this action group, I've been receiving a lot of queries on what we do. And this particular video is about to just make it much more simpler and give you a perspective into what is this action group and what are we doing. And actually, all of you can actually join this whole initiative. It's a pro bono public health research initiative. We don't make a commercial money out of it, but then this is something which binds all of us at a much more deeper impact, given the fact that the crisis we are facing today is essentially a public health crisis and nothing other than that. So I would be speaking about how we are transforming knowledge into actionable insights, and I am Deep Sheet. I'm an assistant professor with the Department of Electrical Engineering and hold a joint appointment with the Center of Excellence in Artificial Intelligence at the Indian Institute of Technology. My research interests are on deep learning and medical imaging, and I'm passionate about how technology impacts humanity and humankind and where we can see the next convergence coming out of it. So what this whole thing is essentially is it's a platform, and this platform is an enabler for anybody with an interest in public health to come and contribute today. We started this with something which can help COVID-19 cases, and the crux of this one is to create a data port. Now, what happens as of today is everybody is sitting on bits and chunks and pieces of data, and in silos, it really does not contribute in any meaningful and significant way. So this data port is an endeavor which we created by which you can contribute to all the data irrespective of whatever format you are recording. So these can be case reports, these can be annotations, these can be clinical reports concerning COVID-19 for the current being over here. And this is an AI-enabled data port which essentially chunks in. If you give it images, it will throw it into folders of images. You give it chunks of text, it will categorize it and then create an ontology tree and then do it. Now that's where it comes down the next part of it as to what do you do with this data. And there are a certain number of examples which I am going to cite over here, saying what we have been able to do in the last 1 month that we have been running this action group. So primarily this is a AI enabled factory, and then it runs on the fuel of AI models. So while AI models are the machines which are getting built up over here, and that too gets designed based on what data you are giving, it learns to churn out more and more insights from this data. And one of these outcomes which we were able to do it in just a very short time was the reporting and data standard for how do you collect COVID-19 case reports and COVID-19 imaging associated data. Now, from here, you can go on to build something which can educate more and more physicians. It can educate public health practitioners. It can educate public health policymakers. And a bigger implication of this is into something which is called as evidence-based medicine. And that's the key to how we are able to treat people and then whether we will be getting down a success in treating down COVID-19 patients or not. And on top of it comes down the fact that we are also a platform to share and list all the contributions which are getting developed in this whole space. So this is not about policy planning. This is not about simulations which are being run. This is a very real problem which we are looking at. And the real solution to this is try to create a AI model enabled space and create white papers which are going to accelerate how physicians get access to knowledge from where they can build insights in order to have evidence-based medicine as a solution being done for the COVID-19 space. If you want to know more, I would highly recommend you to go and visit our website. The links are given over here with its social media and professional media presence over there. And then you get to know more and more about every of these daily advancements which we are making onto this field. Now, this becomes a platform which is an enabler to bridge a lot of stakeholders. Now, the primary stakeholders in terms of knowledge repositories are papers published in journals. You have the hospitals which are doing clinical studies either in a prospective or a retrospective. In majority of the cases, it's a retrospective basis because you don't have a time to sit down and create a way of enrolling patients into your studies in the wake of a pandemic like COVID-19. You have physicians and you have researchers in engineering, in medicine, in biology, in statistics, in mathematics, in informatics, and all of these who come down together, or what today are AI and healthcare and public health policy practitioners together. Now, you need all of these to be integrated together, and on the other side of it you have this power of high performance computing, and that's where a cloud enabled platform as the one which we are putting up together is something which enables all of them to come onto a single common platform to help build more and more insights. Now, this is not all. You also need a reliance and need a dependency on electricity as well as on internet, because without these two fundamental entities present over here, none of the efforts will really be having a scalable benefit beyond just a single user, and then will still be stuck with the same kind of a problem. We are a group of physicians, AI practitioners, and researchers in the field. We took up public health as one of our research initiatives for the need of the time, and really are investigating, putting in our insights from our experiences on the field in order to do it. This is a program which is initiated and coordinated by the Kharagpur Learning, Imaging and Visualization Research Group, which has deep tech insights, and the whole team, a major part of them are members of this initiative, who are members of this initiative are part of this team itself. We also collaborate closely with national and international agencies and professional organizations in the field of medicine, including those which are well known for standardization initiatives, and actually we drive this initiative together hand in hand. Along with that, we also tie up with pro bono initiatives like the COVID-19 EU Challenge and a lot of hospitals which bring on board real-time live clinical insights and data while patients are getting treated, and that helps us make a much richer corpus of case reports. So that's an interesting problem. So let me get you into understanding what is the problem. The question was interesting, but what is the problem? Where are we really standing? What is our impact which we are creating over here? So let's take down a city, a particular geographic location. You have a group of people over there, and you have identified that there is a hospital which can now service as a COVID-19 hospital. Given the fact that it's a very contagious disease, you will need a certain amount of very well drafted and defined isolation policy within the infrastructure of that hospital. So there would be only a given number of beds which you will be able to allocate over here in this hospital. And say that I call this hospital as A, which has just 20 number of beds over there. And we have not yet started the testing. So people in black are people who haven't yet been tested, whether they need to be admitted to the hospital. So they can be either tested and found out to be positive. In that case, you admit them. Now let's look into a numerical perspective of this one. So I'm somebody who comes from an informatics background, and I really love numbers. But then let's speak in terms of numbers, what it will happen. So you might be seeing a lot of these graphs which will look similar to something you have seen in media reports in the recent past. And this is a simulated example, but a much smaller level simulated example to make you understand that a smaller glitch in the whole system can lead to a devastating effect. Now, we take in three factors over here. One is we are just looking at what is the caseload in the hospital, which means how many number of people have been admitted to a COVID-19 bed. The next thing which we are looking at is how many new cases are getting reported per day. And we also look at how many cases are untreated which were detected, and you are not able to admit them to a hospital for some reason. That one of them may be you are just run out of beds. Now let's look at the point. It starts on day one, and then we have something like there is only one person who was detected as positive, and then you admitted that person into the hospital as well. You go to day two, you have another person, additional one person. So now the caseload in the hospital is that there are two people who are admitted, so there are two people over there. Similarly, you keep on going, so on and so forth. So on the third day, fourth day, fifth day, you keep on going like this. You have one person turning positive every single day, and you have enough of beds available, so you are admitting. But then this comes to a hitting point. The point is on day 20, you have actually admitted 20 people in your hospital. You don't have any more beds left. So if on the 21st day, you have a patient who comes down, the only way of admitting him is that you have a patient who is recovering on the 21st day. You have a patient who is recovering on the 22nd day, and so every single additional day you are able to add a new patient because there is one who is exiting out of it. Now, beyond this, what would happen? So we took a hypothetical case that out of this whole population of so many people, that there could be 25 people who would maximally get affected, and they were coming down at one new patient per day over here. Now, beyond that point, you would see that if nobody else is getting affected, then the curve will start to slow down. So your number of beds in the hospital which are getting occupied, that will keep on lowering down because you have more people who are recovering and they are going home, and nobody new is turning up over there. So this is a very good case which comes down over here. And you know that there is no untreated case left out in the community, so the whole chance of a community infection is not present over there. But then this is not the ideal situation. I mean, this may be an ideal situation, but then this is not always going to be realistically true over here. And let's look into another kind of a situation which may come up. Let's take another hospital in a different city on a similar kind of a context over here. And we are going to look into the same number of parameters which we were observing in terms of the organizational management for this hospital on the in the first case, which was hospital A. Now here we start with seeing that every single day there is one patient who gets affected and then is admitted to the hospital. So it keeps on growing till you reach the point of the 20th day when you have actually saturated on all of your beds. But then here also it's going at the same rate. So you will be growing at one more patient per day. Now the patient who comes down, who is confirmed to be COVID-19 positive on the 21st day, you will no more be able to admit them. And then that's that first glitch which comes down, that there is a community presence of an untreated confirmed case which could not be admitted to the hospital. On the second day, what would happen is you will not be having one, but maybe that the growth factor increases to 2. And the reason is that there is one person who is actively COVID-19 positive and could not be admitted to the hospital, so becomes an active source of contamination which goes down. Now, instead of there being just one person who gets admitted per day because of environmental germs or anything, but now that you have an active source, so this is exponentially growing. And this was the main problem which we were facing, and what lockdown brought us together was that we are able to control this from an exponential growth and bring it down to a linear rate, and then eventually we will come to a flat point, and then we will bend and go down, which is the recovery phase. But then for that, it's not just a public health problem. It's not just about extending lockdown or doing anything. It's more about bringing in insights of treating people and how do you treat. And that's an essential thing which we need to really focus on at this point of time. Now that's what will happen on the second day as well, third day, fourth day. So this is like every single day we expire after the 20th day when my hospitals are saturated and I'm not able to admit any new patient because I am not able to treat a patient to recover within 20 days. I am left with a pool of patients out in the community, and which is risking and increasing that. So if you look over here in the red bars, you will see this untreated and yet confirmed cases, and they keep on growing at an exponential rate. So the only difference which we created between the first and the second was, in the first case, hospital A could somehow figure an absolute best case treatment of exiting people within 20 days, which hospital B could not. Now comes a question, can we not really solve it? Can hospital B also not be that wise as was hospital A? So let's look into the situation. One way would be you get both of these hospitals to come down and speaking on a common table and form a working group. It's the age of the internet. We are reaching out through the internet. You have web conferencing systems available. You have all of these mechanisms available, and you can get people speaking, sharing the knowledge. So hospital A comes and says that, okay, this was what we were practicing. Hospital B can actually take in all of those and start including in their practice. That is something which we call as an evidence of what is a success rate. Now say that hospital A comes over here and reports that they basically had two different groups of patients. There was one group in which you had an age group of 20 and 40, and then they weighed between 50 and 60. There was another group of patients who were in the age group of 40 to 60, and they weighed between 60 to 80 kilograms. And now they were administered a set of treatments over there, and then people were looking into what is the evidence over there. Now, in case of the first group, we found that treatment B. So treatment may be a set of drugs. It may be some sort of a therapy. It can be a physical device which is helping you in ventilation and oxygenation. It can be a combination of all of this. Or it can be as simple as don't do anything and just let the person rest. Give them ample amount of space, oxygen, and keep them in isolation. So all of these can essentially be a treatment plan over here. So instead of getting much detail about that, that's something which we will be discussing in the subsequent part. The point is that once you start this, then from here, hospital B can actually pick up that if they can now stratify their patients into these kind of groups, then you know that there is a chance that this kind of a treatment is actually going to work out really good. So that's what is called as evidence-based medicine. And for people with a background in mathematics, you can pretty much recall from your high school level probability and statistics class that this is basically a probability of a treatment given a particular group of patients. So it's just a conditional probability which we are looking down. And now that brings me on to the most interesting fact over here, where I would be merging maths and medicine together. Now this is that crux of the equation which is getting used over here. So in probability, you have a set of conditionals. So what is the probability of a treatment to succeed given a symptom? And that's equal to essentially this whole point over here. So that will take care of the probability of a symptom for the set of given treatments which were administered. What is the probability of a treatment itself happening? So whether we are able to prescribe a certain treatment, whether we did prescribe a certain treatment in a certain hospital or not, and then what was the evidence that a symptom of that sort occurred. Now this is too much of a mathematical jargon which we are putting down over here. Let's look into very simple numbers. We'll do a mock simulated experiment over here in order to understand what that would essentially mean. Now what that means is that we looked that there were two different ways in which you could group patients. So you have one patient group in the age of 20 to 40, another in the age of 40 to 60. And you also have a way in which you have grouped down patients according to their weights. And now what you do is that for hospital A, you keep on observing for 3 days, because on the first day you just have one patient, on the second day you just have another patient. It's really hard to really look at success. You need a couple of days to look into it. And then let's just take hypothetically that I will wait till 3 days, and with whatever patients I have, I will do this. And hospital A saw only 3 patients who came down over here. Now on the 4th day, when I have to make a decision that what kind of a diagnosis do I do, what kind of a treatment do I administer based on my diagnosis for the patient who turns up on the 4th day, then I can make use of this kind of an observation. So what I see is that all my 3 patients who had come down were in the age group of 20 to 40 and they weighed between 40 to 60. And I did not have in any other age group. Okay, great. But then the patient who came down on the 4th day, this guy comes down with a point where he is in the age group of 20 to 40, but then he weighs not in the 50 to 60 bracket, but his physical weight is in the 60 to 80 kilograms bracket. And that's where the problem comes in. You had never seen a patient of a similar nature till now. So what will your probability estimations over here be? And that becomes an undefined problem, because you will essentially have in this equation in the denominator a divide by 0, which makes it an unsolvable quantity mathematically. And then that's a risk factor. That's a risk factor we don't know. So it's still shooting in the dark. Now, to give it a twist, this is what is called as a statistical insufficiency criteria, and it is well defined within the whole paradigm of how we solve something within a Bayes theorem. And that's what you have looked down into this mathematical framework. Now comes the point, is there a way that we can address this insufficiency criteria? So that gets me onto the point, let's look into what are symptoms and what are treatments. Let's try to demystify this part, because if you are not somebody who is in medicine, you will really find it hard to understand. If you have some sort of a knowledge, but then we need to relate it down to evidence-based medicine, and for that I will need to relate it to numbers in terms of how many people presented a symptom, out of who were given what kind of treatments and what was the success rate over there. So let's start with a very simpler process over here. First is, let's start with simple symptoms. You go to a hospital, you are presenting two symptoms, whether you are coughing or not, whether you have a fever or not. So there would be a set of people who would have both cough and fever, who would have cough but no fever, who would have fever but no cough, who would not have fever and not have any cough over there. And then what is a group which is typically called as an asymptomatic group in case of COVID-19. And that's also a much riskier phenomena as of today. So then you can create these kind of buckets where you can group all of these people and just count how many people are there in each of these groups. Now from there, we come down to another point that that's not all of it, because people can have pre-existing diseases. You can be diabetic, you may not be diabetic. You may have hypertensive disorders, you may not have hypertensive disorders. So that's also going to break people down, and these are pre-existing conditions or comorbidities in a lot of cases. And that also influences what kind of a treatment you are given and how you would respond to treatment. But then say that there is a person who is diabetic and hypertensive, which is what comes in the first quadrant over here. They can present any of the other four symptoms, which is both cough and fever, cough without fever, cough, no cough but fever, and no cough and no fever. So that would mean that this whole thing now becomes a bucket of buckets as a combination, something which looks like this. So now, instead of there being four possible options, we came down to another four possible options. So that makes it four options into four options, essentially making it 16 possible options which will come. Now on top of it, you are giving down a set of treatments. So you are administering drug 1 or drug 2. There can be two different kind of drugs. You can give a device support, you may not give a device support, or you give a device support, which is you put them on a respirator or you put them on a ventilator. Any one of these kind of options over there. So that can be the two devices on which you are giving. Now what that would imply over here is that all of these people will form into certain groups who would be given these kind of things, and that makes us go down to a point that this becomes your observation space. Now if you look carefully at it, I mean this is 4 into 4 into 4 into 4, I mean this makes it really interesting over here. So now that goes to the point that we have about 64 blocks over here which need to be filled up with some numbers in order to have a statistically valuable information coming out of it. Now, if I'm trying to do that with just the number of people who get admitted to hospital A, which is one person keeps on coming every single day, that would need me at least 64 days to have at least one person fill up each of these blanks over here. Because if I don't fill it up, then there would be at least a blank on which I have no evidence, no way of actually scaling up and getting my evidence coming here. Now, this is a retrograde move in some way. Because you cannot wait for 2 months. In that 2 months, you would be exploding on an exponential way and beyond the control. And that's something which we have seen in certain countries which have not been able to control, not put down a lockdown, and not have an essential mechanism of how to find out. Because this is the problem everybody in the world is facing. Everybody is experimenting because we don't have any know-how about this particular virus, how it goes. There are some evidences based on the last coronavirus attacks which happened in the world, which was the Middle East Respiratory Syndrome and the severe acute respiratory syndrome, the SARS. Now, that is still an historical evidence and is not a one-on-one mapping on how to really tackle this particular kind of a disease which is happening as of now. Now, one way we can do that is you start pulling in information from all hospitals to the best extent possible. Say that I have 6 hospitals and I start pulling in. This would mean that in about 12 days or so, I will be able to get down my critical mass of information over here. About 10 to 12 days is what I would take down to get the critical number of observations coming over here. And then from there, I can make a table in which I find out that there are a certain number of blocks which are marked in solid. So that's basically that combination where a certain group was responding best when presented with a drug. So the blue dotted box is one kind of an intervention. The red dotted box is another kind of an intervention. So within the blue dotted, green dotted box, the black dotted box, within each of these dotted and dashed boxes, you see a set of how symptoms were presented and then what was the comorbidity and what was the symptom. And then there were a few people who were responding really good over here. And that together gives you your prior probability, not prior probability, sorry, the likelihood of solving out the Bayes theorem. And then from there, you solve out the whole theorem and then you are able to get it down. But then you will see a few of them which are basically hatched points over here. These are the ones which are not responding good. There would be few where you would see that all of them are equivocally responding, and that's a very good symptom. There would be few where there can be two different possibilities in which it can respond, and then that's also good because there are more than one options you are getting none of administering treatment. But then you need to come up with this basis in order to be able to scale up. So that's where all of these challenge comes into. So this is what we call as getting that essential information from the data. Now, once you are able to get this, is when we start seeing the next level of outputs coming in. And then these were essentially publications which happened down in a lot of leading medical journals, in journals of radiology and specialized topics. And what they were providing essentially is, while they were taking care of this really unknown and uncertain disease which is coming over here, what was the success rate? And a lot of these were a result of retrospective analysis. Once the treatment was done, there were sufficient number of success cases over there. Then they started analyzing how many of them were failures, how many of them were successful, and which group of patients essentially responded the best. And that's the point of getting all of this knowledge created from information, which is getting shared across these platforms. Now, the knowledge essentially evolved from those places which saw a earlier onset. So countries like China, Italy, Iran, UK, US, which saw a much earlier onset of this problem before India saw an onset, were providing a richer source of knowledge coming from their side. But then this also creates a bit of a problem. The problem is that there are a lot of sources of knowledge, and we need to really find out a way of how we integrate all of them. Now, on one side, a physician is facing a lot of patients who are just coming in, and the first priority is to prevent the patient from collapsing. So give the first level of intervention so that the patient doesn't collapse. On top of it, if you give them a manuscript from a published paper which is 8 pages to 16 pages, which would take at least 2 to 3 hours to assimilate, and then papers are coming at the rate of 20 to 30 papers every single day. In a month, we saw more than 500 publications related to COVID-19 treatments which came in. This was a very good move. It's essentially a very good move which was done by every single hospital who was willing to share their treatment outcomes to the world, irrespective of whether they were successful, they were failing, or any of them. And this was necessary so that we don't repeat failures in any way. But then you bring in on the table so rich information that makes confusing. That gets confusing into how do you find out actionable insights from all of this knowledge which comes on the table. So one of the challenges is like you will find out contradictory findings. In fact, this is from one of these papers from RS in Radiology, which typically says that there is a very distinct set of findings for adults and for infants who were affected by COVID-19. And that creates a problem. Like, what do I really look into? Where do I look into? What is my test which I would be doing? Now, is there a separate group of tests for adults? Is there a separate group of tests for infants? Is there a separate group of tests for the geriatrics? So for the elderly and aged. This gets us into a problem. And on top of it, there are problems around like what is proposed by the first world. The developed world says that go and get down a CT done in order to understand the inside of your lungs. The developing world doesn't really recommend this one. And then in India, the recommendation is to go with the CXR. The primary reason is our hospitals really lack the number of CT machines you would need to scan. It takes you more than 3 hours to sterilize the room. So you have one patient who is pushed into the CT machine. You need to wait for 3 hours before you can push in the next patient. And in the meantime, if you have a cardiovascular patient, you have somebody with a traumatic injury, you cannot put them into this one. This really curtails, this will completely immobilize your healthcare scenario as of now. So the recommendation over here is to go with portable X-ray scanners for chest X-rays. Now the point is there will be a different set of recommendations because the first world recommendation will not imply over here what you could see on a CT. You are not able to see it on an X-ray, and then you have to start afresh because there is no knowledge at all available. And then there is something from the underdeveloped world where you don't even have access to X-rays, and they still rely on point of care ultrasounds to do it. So that's where it comes down one problem in terms of like, what do you choose for doing that first level of intervention? So what is your first level to find out a diagnostic staging, a risking, a triaging in order to start administering treatments? Next comes the problem that there is no guideline available for reporting. It took a lot of time, and we just saw that in recently in April, somewhere in mid of April was when the first guideline came out from RSNA in terms of CT reporting. But we were facing this whole point that until you know what to look for, you are still essentially hunting in the darkness. Because if I just leave it on a field and ask you like, what do you see? To be very frank, I mean, you might be saying that I see a cow, I see a car, I see few children playing over there. But then there are a lot of more evident things which you were supposed to see and you are possibly not seeing. There is grass, there is soil, there is the sky. And then the point is that when radiologists look into images, they start to look for abnormalities, and you always have a mindset that this is what you are trying to find out a hint for. You are going to look and search for such kind of an abnormality. But then you need to have a list of abnormality for COVID-19. And this being a new disease, this has not been studied. So what people are reporting is what they have evidently been seeing as something which is abnormal, and then you pull in all the information over there to come to a consensus. So it's a very, very time-consuming process, as I would say. Now, once you are able to get that, you will be able to come down to this whole point of actionable insights, and that's what essentially the whole action group is working on. So you come up with a list, a simple checklist of what are the symptoms you need to note down. So these are what did the patient present when they were admitted to the hospital. What are the set of observations which you see on CT, on X-ray, on ultrasound? So this is a sample of the sheet which we created for marking out observations in X-rays. You can have observations from the blood panel, you can have observations from the liver panel, you can have observations from the kidney panel. In fact, more and more people are looking into getting down a whole battery of tests, not just remaining only on radiology. So once you are confirmed through a RT-PCR or a serological test that you have the novel coronavirus 2, the next point is that you need to be certain as to what is the severity of your infection. And for that, you will need all of these kind of things. And using these symptoms and set of observations, the next thing which comes out is to triage or come up with a risk factor. And that's the point which guides your whole decision making over here. Now, once you are able to do that, what the platform envisions to enable is that you have a patient who comes down to the hospital, presents with a set of symptoms and a set of observations, and you basically have a clickable checklist over here. You check, and then based on that, it can retrieve all similar kind of cases which is present within the repository. And this gets enabled when there are more papers which gets ingested into the data port. There is more amount of case reports which all the hospitals who are subscribing are also contributing to it. It's shared on an anonymous platform, so you don't have the identity of the patient coming out of it, but you have the rest of the clinical insights which are really needed for you to now start administering evidence-based medicine. And this is that basis which forms of the evidence. And what we are doing is creating a platform which enables you to start with this. That's actually an interesting question on how we do it. And that's where a lot of the fun lies. So this is about building a whole platform which will be an enabler. And then we have started already working on this one. So what it has is the data port, as I was telling. So this is a platform which ingests data, and it's agnostic to the format in which you are sharing the data. This, however, it's to the best of the knowledge. If you can really link up all the data and contribute it in a very well-defined manner, then the amount of human intervention, amount of AI compute intervention which is needed to really categorize and sort it out becomes much more simpler. And if you're using our RAD sheet in order to create your annotations and reports over there, then it makes it even more simpler. In fact, like I highly recommend you to go and look into our RAD sheet, and you would find it much more easier to use and comfortable, because it's just a simple checklist on an A4 paper which comprises of all the relevant and evident information which you need to keep in order to maintain the complete clinical records for a patient. And then this is built up on a large corpus of knowledge mining, which we have been doing over a large number of published papers and then from across the world. So this where all the publications, more than 50 odd publications have been schemed in order to find this one. Now from here, we build it ourselves, as well as I would highly recommend all of you voluntary developers to come and build it up. You are a data scientist who really wants to contribute in a positive way, then come and help us build better and better AI models, better kind of reporting standards. So the checklist, which I say, is a dynamic document. It keeps on updating based on newer insights and newer inputs which get created from clinical observations. So we would be updating that more and more. We want ways in which you can read clinical data, which is just a textual note over there, and align it to follow an ontological structure description, and then so that it fits into this kind of a checklist. And that checklist is something which enables you to create a case reports browser. So the better ways of filling up checklists are really something which is appreciated. And then that helps us create this whole platform of educating more and more physicians, bringing knowledge right at the tip of their hands, such that now they have access to actionable insights which are really needed at this current point of time for our fight against COVID. And while you are doing all of this, we enable creating a platform where you can share. So host your models on GitHub, host your codes on GitHub, write down white papers and put it on archive. We are going to create a place where we list out all of these contributions based on the data. And then, in fact, we are also releasing out data sets for you to build up these kind of newer and richer AI models. So these are clinical notes, these are annotations, these are things which are taken down from papers, and a large number of publishing groups have essentially now let us have open access to these kind of data forms, have a data sharing license agreement with us, whereby we can now create an open source, non-commercial and share alike licenses in order to release these data sets for richer community engagement in this public health initiative. Now, coming to the point of looking into AI, how we started looking into this was, instead of thinking of this as a really complicated problem, we started thinking in a stratified mechanism, and that has helped us in a real big way. So on the lower level, you can think of simple AI interventions like search, sort, or retrieval problems, and this can be done through techniques which you apply for web crawling, for word tokenization, for spotting of keywords. You have a mid-level set of interventions in terms of spotting out contents on the paper and then combining those contents through some sort of a voting kind of rules in order to come to decisions. And then you go to the high-level kind of an intervention which comes down where you build up machine learning and deep learning kind of models over there in order to do a complete image-to-image diagnosis. You build up graph-based models in order to create better ontologies. You have relationships in order to mine across and find similar cohort and group of patients over there. So that's about discovering newer kind of groupings of patients, newer kind of insights into patient outcomes as well. So it's something which has to go in a stratified manner. You start with simpler problems. As you have a solution to them, you use that low-level data and low-level information in order to create richer and richer insights which are now actionable. Yes, I can really give you an example on how we actually ended up doing this. So the first and then possibly the only example I'm going to give as of now is on how we created the RAD sheet. So it was quite interesting when we started with doing it, because the first point where we hit a bottleneck was there has to be a mechanism of what is that search key which we need in order to search. So what will be those set of search keys? Now, we cannot put down something which is irrelevant. So if I just put down over here that whether you have hair on your head or not, that may not be a search key essentially. We really did not do any sort of a study. I did not find out whether bald people are more prone to have COVID-19 or people with more hair. So I will just leave that one completely off. So when we started doing this, then we started it in a very structured way. So the first point was that you basically search on the web. First thing we searched was reporting and data standards. And we came up with nothing. So this was on the third week of March, and we came up with nothing over there. And that's when we started doing web crawling to find out articles in journals of radiology, in journals of medicine, which would speak out something about reporting and data standards, at least with radiology for the time being, given the fact that serological reporting has standard guidelines, then any kit-based reporting has standard guidelines. You have similar kind of standard guidelines for PCR-based reporting as well. Now, from there, we came up with this set of group of papers from where we did a set of interventions in terms of spotting out contents and salient matter. So, which is an image, which is a text, which is associated with the image, and then you segregate them. Once you have that, then we made access of this wonderful dictionary of commonly used radiological terms with RSNA and the American College of Radiology in order to find and spot which were commonly used terms in radiology. And that helped us come down to create a checklist of known terms. But then there were a set of unknown terms as well, like which was not present in RSNA radiology or the ACR common data elements. And the reason was they were observations which we were seeing for the first time in chest CT or chest X-ray. We had never seen similar kind of observations. There were new kind of anomalies which are coming up. That's the key point. Identifying such kind of spottable terms which are really new are something we need to keep into mind as of now. And that helped us create one part of the checklist which is based on known contents, another which is not based on known contents. And then this version 0.1 was what was sent out for review. Review with images, a lot of blind reviews where annotators were just annotating what they could see on images without knowing whether it was of a COVID-19 positive or a COVID-19 negative and what was the severity and risk. Now that all of these opinions and votes together getting aggregated help us create a data-driven mechanism of aligning symptoms to a certain triaging on the severity and risk scoring. And that is what is available today in the RADS v0.2. And now, based on this, we are collecting more and more data, which is enriching this one, and we would sooner be releasing the COVID-19 RADS version 1, which will be a much richer data-driven and analytics done on top of it in order to come up with an exact checklist and also have an identification of what is the risk category and triaging, and also draw down parallels between multiple modalities. So if you see a certain kind of observation in point of care ultrasound, what would be a similar kind of an observation seen in X-ray? What would be a similar connotated observation which you will see in CT? And that's an interesting insight which we are building up over here. So that's how we built up this whole sheet over here, which is the reporting and data standard. I would highly recommend that you go and have a look at it. There are 3 reporting and data standards, one exclusively for point of care ultrasound, one is exclusively for X-rays, one is exclusively for CT. And around the same time, in fact, RSNA was also putting in their efforts, and today we do see that RSNA has a similar kind of a reporting standard template. And in fact, there's a lot of parallel between both of us. So they also put down a whole effort. The only difference was that we were doing it by mining out insights from papers, and RSNA was doing it by putting down active working groups of physicians. And the time they took in order to do this was significantly larger because you need to get accessible time of humans, get their insights, get their presence of mind over here to work it out. And sometimes it's really challenging in terms of pandemic situations like this, where it may be easier that you can have AI-based methods and techniques to accelerate the process. Then you have humans to verify the outcome over there. And it's just about how you find out ways of really accelerating your process when you are limited by time. So if you are looking at this question on how you would like to contribute, the best way is that visit our site and you would find out this one single line banner over here which explains how you can contribute. So you can be a radiologist, contribute in terms of images. You can be a physician, contribute in terms of contributing case reports to the data port over there. You can be a public health researcher who can help us analyze and review all of these. You can help us create better and better insights and how the data ontology can be worked out. You can be an AI scientist or a data scientist who can work out and creating better and better models to accelerate the process. As a policymaker, you can take back all of these policy materials and matters and really get it into practice, because that's what we are building up actionable insights for. You can be a volunteer or an organization and come on an independent capacity. We really don't know. You can have a wonderful superpower which you need to bring really on the table. So the superhero hero today is not just a few people who have been listed as superheroes, but each of you, each of us is a superhero over here who can come and bring onto getting this public health initiative driven. You can be a professional association, engage with us in getting down these kind of standards and how you can help each other build our with our strengths together. You can be a pro bono initiative. Let's join hands together instead of competing, and that's what we are doing with a lot of pro bono initiatives. You can be a challenge which is getting hosted to create more and more AI models. Join with us. We can get you more and more access to better quality curated data which comes down from us. A larger treasure trove instead of you trying to now invest time to find out that part. You can be a university, you can be a hospital, you can be an institution, you can be an industry, and you can bring in data, you can bring in compute, you can bring in resources, you can make this platform scalable. And then all of these are welcome initiatives which we are looking forward to the community to contribute to. If you are really at this point that you are really motivated and want to join hands, then I would strongly recommend that you go on our website and click on enroll button. So that takes you to a form. It collects a few set of important information. I mean, all of this is kept anonymized. It's not shared with anybody else over there in any way until and unless you really acknowledge and agree to be sharing this information at a later point of time. So that brings me to the end of this long, invigorating discussion which we have been having. It took us about 40,000 years to come out of the cave and into this civilized society where we were mingling and having a real good social life. And it took us just 3 months of COVID-19 to push us back into our silos, our own caves, our homes, get into a house arrest condition, because that was the only way to find it out. So our predecessors, the cavemen, used to be afraid of the dark. We are afraid of going out in the public, in the air, because the virus is looming large. Now, the way is you can actually join hands as humans plus AI together in this fight against COVID-19. And that one of the biggest ways you can contribute is by enabling how we transform knowledge to actionable insights. This is one of our endeavors which we are putting down towards it. You can have better and better quality ideas. You can bring it on the table. So I strongly recommend that you visit our website, tell us more about how you would like to engage with us, and let's join hands together in getting this formidable foe really down.